And I think all the first is for the day.
Oh.
Right now.
Starting right now. And I'm coming down here because I don't want to stand back there. I like close meetings. It's way cool. This is one of the subjects that most people avoid. And this is the one that will make what you do a lot nicer. So that's why we put this together. This is not unlike you second years have already seen when we did coding and billing, but this is a little bit more down to earth. Of course, it doesn't work. Is it on? Okay. That's dead. Okay, there's your sign-in code for whatever the folks that want to sign in. I'll leave it a minute just in case there's somebody out there. Okay. Get rid of this. I'm not going to read these to you, but these are the reasons we're having this little talk. This is a whole different ball game as far as coding. It's not like what we talked about. It's not a 99213. It's not any of that. It's completely different. And it changes. You really have to pay attention to the location because most of the things that you're going to code are in the office. But then this takes you to a whole nother world where you might be coding in a rehab center, you might be coding in a hospital, you might be in their home because it's a special code for home visits. And this right here is, you got to do it the right way or you're not going to get paid. And many people who come to you with disabilities are going to have minimal insurance, or they're going to have Medicaid, or they're going to have Medicare, or they're going to have both. Yes, children can get Medicare. I was one of the only pediatricians in the whole North Texas that had a Medicare number, okay, just because I had that many people with special needs. The other thing we're going to talk about a little bit is how to document and what to put in your documentation. And we're also going to talk about the evil letter of medical necessity and how to write one. There's even some samples in here of how to get started on a letter of medical necessity because they're going to come in, patients are going to come in needing a piece of equipment, a medication, something like that, where they've got to have special dispensation from the insurance company to get it. And my friend Cody knows all about that. I know all about that. So it's going to show you how to write that letter. And also you need to be aware of your referring pattern, to whom you refer. And I'm going to talk a little bit about that because it's really important to figure out to whom you're going to make referrals before you ever do it. There's nothing in an insurance policy that tells you how to do any of this, okay? You're not going to read every patient's insurance policy when they come in. They sure haven't read it because it's probably 800 pages and they don't know what half of it means because it's written in legalese. Therefore, they're not going to know what their insurance covers or not. I tried to tell people, parents and caregivers, to check with their insurance carrier, with their case manager, if they had one, to find out what was covered. Half the time I found that the case manager didn't know what was covered. And certainly if it was something like an enteral feeding tube or Mickey button, PICC line dressing change kits, they didn't even know what that was, much less get it reimbursed. So that's why it's important when people come to you, especially if you are in a practice where you're seeing people who haven't given birth yet. They may know they're going to have a child with special needs. It's imperative that you help them find an insurance carrier that's going to help them with some of their expenses and be sure that they know exactly what the kinds of questions to ask. Most of the health care in this country is covered by, government agencies like Medicare and Medicaid. Private insurance pays for some of it, but sometimes they don't pay for anything. It just depends on the policy, and it depends on how much money the parents have to spend on it, who's working, who's not. Usually there's only one person working because the other one has to stay home with the person who's disabled. And many times you only have one person working. And as a physician, it's imperative that you try to recover as much revenue as you can just so you can keep doing what you're doing that you love, which is taking care of people with special needs. That's the reason I put this together, is because that was something that I struggled with every day. And in the middle of a busy practice, I didn't have a whole lot of time to worry about it, but I had to. You got to add all the modifiers in any code that you can come up with that affect this patient, because the more codes you've got on there, the more likely you are to get something for the visit. The good news is now we can actually bill for time spent in the office. Back in the old days, that was not the case. Now you can put on your documentation how long you spent with the patient, and that's going to affect what you get paid. Because some of these things I've listed up there, like education to patient and caregiver, asking about medication in interactions, reassuring the patients a lot of the times, because sometimes they have a lot of anxiety, especially if it's someone who was not previously healthy and now has a disability secondary to an accident or an illness or something. You might have to help troubleshoot equipment, which is why we had that whole equipment lecture, because you need to know how it works, because they may not be able to get a hold of the healthcare company. Whatever may happen, or it may break and they can't get a hold of anybody, or it's the middle of the night. They're going to help. You're going to have to help them. And you got to help them with their environment. They may need to move. I know we had to help some of our patients move into a place so they could have access, because if you're on the third floor and it doesn't have an elevator and you're in a wheelchair, it's an issue. So you forget getting reimbursed for travel time or any of that, because you're not. That's on you. And you have to make sure that when you're coding, because what that code is, it's justification to the insurance company that you did something specific. And they want to know this because they use that information for underwriting and to justify any shared premiums like copays and stuff like that. So it's really important. Also, it's interesting, I found, because the insurance companies come out to your office usually on an annual basis and review what you've done and all this stuff. And if you've done a good job with coding, they won't come as often because they know you're doing the right thing. And they'll also give you compliments. I was complimented on the fact that I had fewer ER visits than most of the people who didn't care for disabilities, because we took care of a lot of it in the office. Like most pediatric offices, if the child's G-tube falls out, they send them to the ER. We replaced it in the office because we all knew how to do it. And we didn't charge extra for that. It was just part of the visit. And it was a whole lot cheaper than having to go to the emergency department. Here's some coding that you might want to save, just because these are the right codes. And again, there's only a few of them. This one here is just for new patients, but you can see for yourself that the code numbers go up based on what's wrong with the patient, how long you spent. And there's not really a time that's associated with each one of these, but it has to do with what you already know for office coding. If you spend 15 minutes with them, it's probably going to be a 341. If you spend an hour or an hour and a half with them with all the education, it's probably going to be a 345. But you have to write enough stuff in the charts so that the insurance company knows you did it. Existing patients is a little different. These are people you've already seen before. And actually that 99345, you can actually use that for a new patient, comprehensive history and physical. You might make sure that if you write that note that you put in there, you reviewed previous records, because that takes a lot of time, especially for complex patients. And you want to get paid for your time in that, because if you don't review the records, then you're not going to be able to make good decisions. Here are the existing patient codes. And here are the most frequently used modifiers. Yes, you can put a modifier on these. If it's a repeat procedure by the same physician, if it's a mandated service, and that doesn't affect special needs quite as much as some of the other things do, but also a separate E&M service, that's where your OMM comes in if you're going to do OMM. You can still put an OMM code on there if you do OMM for the patient. This is huge. It's a little bit easier now that we have electronic health records, but a lot of the things that you're going to see in complex patients is not going to be on that drop-down box. You're going to have to free text it. And there is a new medical record system out now that my son has got a hold of that's got intelligent language, where you take the computer and you bring it in the room with the patient, and it records the entire conversation and then charts it. Yeah, you have to go back and read it, but that's a whole lot easier than previous things, and it gets the nuances of the things that aren't in the drop-down box, because these are people that have something special. You got to make sure that when you do your documentation and on electronic health records, you got to make sure this is right. But remember, it's garbage in, garbage out. It's only as good as the information that you share with it. You got to say where the visit happened. You got to say what the visit was about, what happened since the last visit, things you've already been taught. Now, there are some electronic health records. When you buy a record, it comes with a special package for complex patients. There's 2 or 3 out there now that actually have that. And if you get lucky, you might be able to get one of those. But if you're working for somebody else, they may not have that. Anything that was rendered, certainly any treatment that you might do during that visit, replace a G-tube, replace a PICC line, remove a mole, any kind of things like that, you need to put in that note as a procedure. If you change any medicine, this is huge, because if you change a medicine or add a medicine, you got to put the patient instructions in there, and that takes time. If you go to a home visit, please put the environment in there. That's a whole separate category. You can say, visit a patient in their home, found it to be clean and neat, or found them to not be in a healthful situation, found that they did not have clean bedding. I mean, that kind of stuff, because that's going to make a big difference later. It may be the point where you have to call Adult Protective. I mean, if it's bad enough, but you won't know if it's not written down. And again, I hate to mention legal things, but sometimes if it comes to court and somebody needs to be removed from their environment, they look at the medical record very closely. I know, because I do that. That's my side gig as an attorney and that kind of stuff, medical neglect. So make sure you include any conversations. You don't have to write the whole conversation out, but any kind of the subject of any conversations you had with the patient, the parents, the caregivers, any people like that, so that they know that you spent time with the patient. Remember, these are not 5-minute visits. They're not even 15-minute visits sometimes. Oh, this thing. There it goes. Sometimes patients come in with needs that can't be met in a regular CVS or Walgreens. And sometimes it's medication, sometimes it's equipment. Sometimes the home care company, in order for them to get reimbursed by the insurance company, for example, a hospital bed, you have to write down why the patient needs a hospital bed and can't use just a regular bed that they got at Ashley Furniture, for example. Because sometimes you can't. If you can't get in and out of the bed, or if you need the back lifted, or some reason that you need a hospital bed, and there are people who need those. The only way the home care company or the equipment company is going to get paid is if the insurance company pays them, because the family probably doesn't have, well, you can remember that last slideshow a few times ago that talked about the hospital beds that are like $6,000. They're $6,000. Nobody's got that laying around in a jar, okay? So it's important that they get paid. And bad part about this is everybody's got their own form. And yes, it's electronic now. It's still the same. It's still a thing. There's not a form. Medicare, Medicaid, they have two separate ones. If the patient's got both, you got to fill out both. So what you're starting to see is this takes time. You can't just, shoo these people out the door because they need their letter and they need it now because they need their hospital bed. It might be 2-3 weeks before it can get there anyway, but the longer you wait on these things, the longer it's going to be before that patient gets what they need. So you have to get that form completed. Sometimes, in addition to the form, you will have to write a letter, and I've got a sample of one right here. In a minute, you'll see it, because they want to know that you actually saw the patient. They want to know if you made the diagnosis or who made the diagnosis. Is it correct? That's why it's called a letter of medical necessity. Is this really needed? The problem is there's a lot of fraud out there, guys. I hate to say it, but it is. There's a lot of people out there. In fact, it just happened in Dallas about 2 weeks ago. In fact, it happened was it here? I think it was in Dallas. Somebody got marched out of their office and put in jail for Medicare fraud from equipment. They were billing for equipment that was never gotten and getting paid. They were getting paid a whole lot of money. So it's a problem. That's why they have all the rules in place. But you can save the patient a whole lot of time and energy if you can just get the letter done. You might want to save this for posterity, because this right here, it's a little hard to see, but it tells here what the letter has to have. And you can use your own, they want it on your letterhead too. They don't want just a piece of blank paper. It has to have in there the details. We already talked about that. Treatment recommendation and why this particular piece of equipment is going to make a difference in this person's health care. And you have to have all the documentation, and you have to be legit. That's why it has to be on your letterhead. And this right here is a great example, and it's blank. You just plug in what you need. And I can't tell you how many of these I wrote. Thousands, maybe, in addition to the form. Because the wonderful person I had working for me that was an RN and didn't want to do that anymore was my transcriptionist, and she was super fast. She could turn 90 charts around in 24 hours, and she would have the charts laying up on the counter when I got to work with the patient's chart, the form, and my letter. All I had to do was sign it. And if you got somebody that you can hire that can do that, you're in business. You got to look at it to make sure they got it right, but wow. And then you got the computerized form now. You got to get online and do all that mess. And if you can find somebody you can train in your office to do it, it's great, but mostly you're going to have to do it. But as soon as it hits the door, don't put it over here and say, I'll get to it later, because you won't. I know. I got a lot of patients off the letter of medical necessity that never got written. Okay. They came to me because they knew the grapevine said, go to Stanzac, she'll turn your letter around 24. And the other doctor would just put it over here and keep putting it off and putting it off. It's not that hard to write. You can see it's easy peasy. Once you know the patient and have their chart and have their information with all their diagnosis and everything. But you just have to do it in a timely fashion so that the patient can get what they need. This is another thing that you should be aware of and help with, because this is huge for patients and their families. Yes, they might have Medicare and Medicaid, but that doesn't pay for everything. And if they need respite care or something like that, they don't pay for those things. That's something that comes out of the family's pocket. Many people who have disabilities are eligible for state and federal programs. You need to find out what they are in whatever state you're in. Here in Texas, we have a few different programs. There's Medicaid spend down, and that's income based. If it's for you and you don't have any income and you're on Medicare and Medicaid, you can probably get on that program too, and that will help you offset costs of equipment that the other things don't pay for. There used to be a children with special needs program here in Texas. I don't know what they call it now, but that was real important because that gave families something to fall back on if all the other, even if they had private insurance, they could use that. And you just need to know about these things because the families are not going to know, and they're looking to you to help them get through this. And so it's really important that you be aware of it. And you might be able to help, if sometimes the hospital social worker can help you with this, if you can pick up the phone and call them. Sometimes if they're discharged from the hospital, that's already in the works, but don't count on it. You need to trust but verify. You need to go back and make sure that somebody got the ball rolling on that. Finding support groups, especially when it's a child with a disability, finding parent support groups is huge. And they usually, yeah, now you can find them on the internet, but a lot of times one parent will know another parent will know another parent, and they'll ask, can I call such and such, or is it okay if I contact them? And I haven't found a parent yet that didn't want to be with another parent that had somebody just like them. And there's a lot of community groups. If you're in a bigger place like here in Houston, there's a lot of community groups where people get together once a month and talk about things. But again, it all comes back on the physician to get out there and find resources for families so that they can pay for what they need for their person with disabilities. Here's something nobody talks about, and something that we actually put together. Actually, my husband put it together because I was in the Dallas area, and I'm in Dallas-Fort Worth. I had a lot of folk out there. There were lots of docs. Well, who's going to do the best job with my patient? Well, I didn't really know. And the only way you're going to know is to send someone there for referral and have them come back and tell you. Well, it takes about a year or two for that to happen. But once it does, you know exactly where you can send your patients if they need a neurologist or they need an ophthalmologist. And you can write their names and numbers down. And we had a very specific list in our office of all the agencies and all the physicians that we used for referrals, what their phone number was. In fact, some of them, we even knew their office manager's name because we called them a lot. And it's good for their business. It's good for me because my patients don't have to wait 2 months to see somebody. I can pick up the phone and call my ENT that's down the street and said, hey, Dr. Jones, I'm sending you Johnny Smith. I think he probably has probably going to need a cochlear implant. And, you know, it is done. And they see them like 2 days later and life is good. Rather than send them to a clinic or send them to somebody you don't know. Back in the old days, back in the dark ages of medicine, we used to write a letter to the doctor to whom we referred. Dear Dr. Smith, I have the pleasure of caring for Johnny Jones in my office. Johnny has blah, 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 and, you know, fill in the blanks. Here's why I need you to see him. Thank you very much for your time. Signed, me. And we put them in the mail back in the day. Then we faxed them. And next thing you know, we're sending an email. But the trouble with email is, I know this to be true, is most physicians don't look at their email. So sometimes it works a lot better if you do send it through snail mail. At least it comes to them to the office and somebody opens it and says, hey, Dr. Jones, you need to read this. So it's important to tell the physician to whom you refer who's coming, why they're coming, and what your expectation is so that it can be met. The problem right now in medical care is that people get referred to subspecialists, and the only way the referring physician ever knows the outcome is when that patient comes back and said, I had a terrible experience. They didn't take care of the problem. They sent me 12 other places. I got $8,000 worth of x-rays. Didn't you know? And I'd look at them and go, nobody ever called me. And that didn't happen when I had this list, okay? Because these people knew me and I knew them. And they knew that if I didn't hear something in a timely fashion, like within a week, I would be calling their office going, hey, did you see Johnny Jones? What did you think? So this is important. Just write it down, put it in a little notebook somewhere, make sure it's where everybody in the office can find it. Again, this has to do with staffing and having a staff that's going to help you out a lot. We had also on the wall, all the early childhood intervention, all the mental health agencies, what used to be called chronically ill and disabled children's programs, adult and child protective, all those numbers were on the wall. They were in a little laminated book on a hook so that anybody in the office could pull that off and make a call if they needed to. Also had primary services listed at the local hospital that we used. And we had some of them on speed dial, like radiology and that kind of stuff. But these are numbers that you just keep out there. And why does this have to do with reimbursement? Because it saves you time. It makes sure that it's going to be reimbursed appropriately on the other end if you make the right referral. So it doesn't seem like it fits with this, but it really does, because if you have good people to whom that you refer your patients, it's going to cost them a lot less time, you a lot less time, and it's going to get the problem taken care of in a timely fashion. Now, when it comes to some of these things, you can also find out when you call the physician to whom you refer if they are on their insurance or not. How many times have people come into the office and said they sent me to Dr. So-and-so, but they didn't take my insurance, and I didn't know till I'd waited 2 weeks for an appointment, and we sat in the waiting room for 2 hours. I'm sorry, that's mean. Before you send anybody anywhere, you need to know if they take the insurance that this patient has. That's also on this referral list. By every doctor's name was in parentheses what insurances they took, if they accepted Medicaid and Medicare, all that stuff, because I'm not going to send somebody someplace that's not going to take your insurance, because I'm not mean. And what we're trying to do here in this medical school is teach y'all to do the right thing and not be mean, because not everybody knows everything you know. So it's important to know that. And that's one of the things that you've got to put on your referral list is who can they see? And you might have to get a pre-certification. Oh my goodness, it's another form to see that person, especially if it's somebody that they absolutely need to see that's a super subspecialty. Example, pediatric dermatology. If they need to see them, the insurance company, if they have regular insurance, is not going to want to pay for something like that unless they know why. Again, referral letter. Number two, it's absolutely necessary. So you're going to have to write a letter and call the insurance company and get a pre-certification number. And they'll give you a number over the phone. Put that on the letter. Then you're all set. But that happens too. And that's another email, and that's another electronic form you have to deal with. And I'll tell you who we had on speed dial in our office were the medical directors at all the major insurance companies. I didn't even fool around just making the 1-800 number. I called the medical director's office and said, hey, it's me again. I need this. And it just expedites everything. So if you're going to take care of anybody, I don't care if you take care of only 2 people with special needs in your practice, you still need to know all this stuff. And when you get into an area where you're going to be practicing, you just have to take the time to find out. And find out for yourself. Don't ask somebody. Ask your patients. They'll know. Now, you said, wait, what? How am I going to see patients if I got to do all this other stuff? And the answer is you can. You may, and you should, train a couple people in your office to be able to do a lot of this stuff. If somebody you value in your employment, doesn't have to be the office manager. It can be some person that works in the front office that is good at this. But these are some of the things that they've got to be able to do in order to do it correctly. So it's not done correctly, patient's not going to get their care that they need, and it's going to have to start all over again. So this stuff, getting approvals for referrals, medical equipment, it takes time. I mean, it really does. If you delegate, they have to be familiar with the process. They have to have worked for you for a while and understand how medical offices work. And they have to understand lab values, chart notations. They have to be pretty good. They don't need to be a nurse. They don't even need to be an MA. You can teach anybody this stuff. I know I did. And they were really good at it. And that's the only reason I've survived is because I had a couple of people in my office that could do this. And if they knew when they'd get stuck, they'd come get me. But it wasn't often. They also have to understand special tests, any special instructions that a patient might need. And this is true of everybody in the office. But then we had office meetings. We had office meetings every week, and this could all be brought up. And I didn't have a lot of turnover in my staff. In fact, I had almost none. And that's because I hired correctly the first time, I'm pretty sure. But these are some things they need to know. They need to understand how insurance companies work. They need to understand how to get the correct information and what to get. And we actually put this in a little handbook that everybody had in the office. We wrote it all down for them, and it was like 4 or 5 pages. And that way they had a reference and they didn't have to come pull me out of a room or go find the office manager. They needed to be able to tell over the phone a brief history of the patient because they're going to want to know that. So it's important that they learn how to look at a chart, read a chart, and be able to convey that information to the people on the other end. And they may have to tell the patient what's going on, so they have to be able to relay possibly frightening or scary information to the patient and the family. So that's real important that they be able to do that and not lose their cool. Right now, my daughter's working in the emergency department in Oklahoma, and they have deemed her the patient whisperer because she can calm anybody down. I don't know why. She lived with me, so I don't know, but she's really good at it. And so they come get her for everything. But she has that demeanor that she never loses her cool. So she can talk to people that are even life-threatening, that sort of thing. Also need to know, these people need to know when to follow up with the referral source. If you don't hear anything, you don't wait 2 or 3 weeks. If you call on Monday, you should get a call back by Wednesday or Thursday. Nobody's that busy. I'm sorry. If you're that busy, then you don't have enough people working in your office, or you don't pay attention to detail, and then I don't know if I'm going to use you as a referral source or not. And it's usually not the physician, it's usually the staff. So, and they also need to know when to tell you, hey, I haven't heard back from Dr. Jones. You want me to give him another call? Thanks, do it. And they've got to be able to document. Oh my goodness, this is what gets people in trouble in charts, is they let somebody else chart stuff and they don't do it completely or correctly. And that comes back to bite you later. So make sure that anybody you teach to make referrals and do these things knows how to document and check them. There'll be a time when you won't have to anymore, but at the beginning, you need to check every bit of work they do. But that requires that you know what correct is, which is why we're having this talk right now. Because if you don't know what correct is, you can't tell if it's being done correctly or not, and that will get you in a whole world of trouble at some point in time. So that's the referral process. Sequencing. This is huge. People say, referral. You just pick up the phone and call Dr. Jones and say, I'm sending Johnny over. Not so much. It's not that easy anymore. Used to be like that, but it's not anymore. These are just some helpful hints on how to make a referral easier. Just simply ask ask the referring physician if they have a preferred physician or company and the time frame for the confer. Get all the information, facts before you make the call. If somebody needs a referral, we had that list, so they didn't have to ask me anything. They just looked on the list and figured out what specialty it was and just made the call. That's why you have to create the list. It took us about 2 years to make that list, but man, it was a help when we finally got it finished. You call the office, get an appointment, get the third, you got to call the insurance company first. You can't call the referring physician first. You got to get a number, okay? Especially commercial insurance. And Medicaid will want some sort of referral letter. I'm told now they even have a number that they'll give you. You call the subspecialist office, make sure you got that third-party approval because they're going to want to know. And you already know if they'll take Medicaid or Medicare because you've already got that on your list. Make sure you inform the patient and family. And if there's any special instructions, don't eat before you go over there because you're going to draw your blood, whatever. Make sure that the patient gets that from you because the other office may not call them back and share that. So make sure they have the information. Make sure that you put in the chart that the referral is done, and that can go in your plan, referred to Dr. Smith, appointment is blah, blah, blah. Here's why I referred them. That can go in your plan. and then give that information to the referring physician so they can send so you can send a letter or email to that subspecialist and they know. And this is what your person's going to do that's going to help you out. And then you may get a phone call from the family saying, who was that doctor again and where were they? Make sure you get instructions on how to get there. I can't tell you how many patients came in my office and didn't make a subspecialty appointment because they didn't know how to get there, because it was somewhere else. It wasn't anywhere near where they lived. And this was before Google Maps, okay? And some people can't use Google Maps or Waze or any of that stuff. So you might need to hand them a paper map on how to get there. I mean, it depends on where you live. And if they're people like where we were in the middle of nowhere, you might have to give them specific instructions on how to get there. I mean, and I know that sounds really simplistic, but if you've not had to travel around a lot, it's a real deal. And you don't want your patient to miss an important appointment just because they couldn't get there because they didn't know how. Now, many of the offices will give them instructions on how to get there, but make sure you do it too. Don't ever depend on the other office to do as good a job as you. So this is one of the things that you can do to really expedite things. And it's how you can train your staff to help you so you don't have so much work. I love my picture. I actually had that on the outside of my door the other day. Normalize caring about people who are different than you. Yeah. It's not a bad thing to be different. But this whole thing is so that you can get paid for doing this, because not everybody's going to do it. And like we talked at one of the very first talks, there are 47% of people with disabilities do not seek health care. And the reason they don't seek health care is because people won't see them because, number one, they don't know what they're getting into. They're afraid of them, honestly. That's the truth right there. They don't understand the complexity of what that patient has. They're very afraid that they won't be able to get paid for what they do. And it's not about the money, folks, but you have to keep the office open. And if you were like me and had a 60% disability population and 70% Medicaid, it's an issue. It's not still not about the money, but you need something so that you can see more people with disabilities. And if you don't have any money and you go broke, then you can't see anybody. So that's why this whole PowerPoint exists. And it came from investigation, asking questions, and finding out that there's always a way to get around and get things taken care of, even when the patient doesn't have any money. And we spend a lot of time on that. That's another thing you can teach your staff to do, is help you find resources for patients. You'll be amazed what they can do. And sometimes you win and sometimes you don't, but more often than not, you'll get what your patient needs, and that's what it's all about. And you'll actually get paid. And people said, well, didn't you have to see a lot of people on private insurance to take the weight off that? No, that's a myth. That's a myth, completely, totally a myth. They may not pay me either, but we had to take care of it. And if somebody came in and they didn't have their copay, I didn't care. You're supposed to take it because it's a pact between the insurance company and the patient. If you don't make the copay, then they don't have to cover the visit. But if you don't have it right now, you can bring it next week sometime. Or make me some cookies. I'll throw 20 bucks in the till. I mean, that's how you do it. And that's what we're trying to teach you here at this school, is how to do it right thing. That's why you can't go to work for corporate medicine, because they won't do this. I was told, frankly, by the Carl Clinic many years ago, we're going to tell you who to see, how to see, when to see, and how many to see. No, we don't do disabilities here. They go over to the rehab center. Sorry, I'm not going to play. We offered you a good salary. I don't care. I'm taking care of these people because somebody's got to take care of them. So bottom line is, do the right thing and you'll be all right. And with that, I close.